Assistance of Child and Adolescent Health Initiatives here at the Association of Maternal and Child Health Programs, or AMCHP as we call ourselves. Thank you so much for joining us today for this webinar on understanding the Illinois Family Recovery Plans Implementation Task Force Act, opportunities for strengthening collaboration and policy capacity. We will be recording the webinar today and sharing out slides afterwards, as well as a summary resource. And I will go ahead and move us to the next slide. So we first just wanted to acknowledge the funding that supports this work. We're really grateful for our funders at the Foundation for Opioid Response Efforts, or FOR, and the Perinatal Fund. The content presented here today is the responsibility of them and does not necessarily reflect the views of FOR, Perinatal Fund, or AMCHP. And I am just going to do some quick speaker bios and hand it over to our incredible speakers. So today you all are going to get to hear from two incredible physicians. We have Dr. Ruchi Fitzgerald, who's an assistant professor in the departments of family medicine and psychiatry and behavioral sciences at Rush University. She is also the associate program director of the Rush University Addiction Medicine Fellowship. She is the service chief of the Addiction Medicine Consult Service at PCC Community Wellness. They're a federally qualified health center system that serves the west side of Chicago. Dr. Fitzgerald was awarded the National Academy of Medicine James C. Puffer American Board of Family Medicine Fellow Award in 2002. And Dr. Fitzgerald's work has focused on really promoting cross-sector collaboration to improve care for persons affected by substance use disorders, with an emphasis in the perinatal child health arena. Her scholarly work has focused on addressing stigma, building capacity in primary care for treating opioid use disorder in special populations, and implementing evidence-based substance use disorder curricula and the next generation of clinicians. She has also focused on expanding treatment options using a health justice framework for older adults affected by severe opioid use disorder. And Dr. Veena Ramaiah began her pediatric career as a pediatric emergency medicine physician when she joined the University of Chicago as faculty. Since the Pediatric Emergency Department is a site where victims of suspected child maltreatment frequently present, this sparked an interest in child abuse pediatrics, or CAP. She became sub-board certified in CAP in 2013 and straddled both worlds for many years until finally turning to the world of child maltreatment full-time in 2020. Her clinical work in the area of physical abuse, determination of manner of injury, and neglect has evolved into research examining the quality and outcomes of investigations when a collaboration between child welfare and physician is required rather than optional. She is also a co-chair of the Illinois chapter of the American Academy of Pediatrics Committee on Child Abuse and Neglect. In this role, she leads the child abuse experts in Illinois in advocacy and legislative work to protect children from harm. Someday, she hopes to expand her scholarly work to include prevention efforts before children are abused or neglected, and the work on family care plans is a significant step in this direction. So thank you both for being here today, and I am going to hand it over to you.
Thank you so much for that introduction. I'm so pleased to be here with all of you. I know Dr. Ramaiah feels the same way. Neither of us has any disclosures today. I'm going to just take a moment for myself to just acknowledge a couple of sources that have been key contributors. So that would include the Children and Family Futures Organization, as well as Movement for Family Power. ONDCP during the Biden administration had some great resources for me. A colleague of mine, Dr. Stephen Patrick. And so I just wanted to take a moment and acknowledge them, as well as the Center for Disease Control for providing some data sources, and the Illinois Department of Public Health. Thank you so much. Let's move to the next slide. Okay, just to run through our learning objectives for today. So the first is to explain the importance of family recovery plans in supporting the holistic needs of infants born with prenatal substance exposure and their caregivers. Secondly, we'll be working to identify the key steps, partners, and strategies involved in developing and introducing the Illinois Family Recovery Plans Implementation Task Force Act to the Illinois legislature. And lastly, discover how the lessons learned from this development of this act could inform the creation of similar policies in other states to improve outcomes for families affected by substance use disorder. Next slide. For those of you who have heard me present before, you might be familiar with this beautiful piece of artwork by Nani Chacon that was, respectfully given to us to share by Bold Futures in New Mexico. As we can see here, it's a depiction of a woman who is pregnant, who has thorns, wrapping around her arms, representing the criminal justice system or incarceration with the quotes saying, I am more than my addiction. I'm fighting for those who I love, fighting for my life. And that's really just a great example of what motivates me to pursue policy work and just provide care for this population, as well as for the families and their children. One of the quotes that I'm including here has to do with one of the moms I cared for many years ago. I went in to get help. I wanted to stop using. I did not know they would take my baby from me. I was born to a mom who was addicted, and I never wanted to end up like this. Just, can be pretty emotional looking at this, but also takes a look at like just, population wise and communities that are affected by substance use, how this can be generational, and how we as a team can look to support these families in a better way rather than punitive approaches if possible. Next slide, please. So I'm a pretty simple person, and this is a complicated topic, especially as we bring in like the legal aspect. But the big picture view really is that, in our country and across the world, citizens, people have always, used drugs and alcohol, and some people overuse and develop an addiction. The medical term is substance use disorder. And some of these people are women, and some of them will become pregnant. It's pretty rare for someone who's pregnant to start during their pregnancy using drugs or alcohol. I've only seen this a couple of times, and like I said, that's extremely rare. Typically, people are already having a substance use disorder and then become pregnant. It's a treatable medical condition. There are evidence-based treatments, FDA-approved treatments, behavioral health treatments, and with the right supports, people can and do recover. There's no one pathway to recover, and that's been widely acknowledged by one of our federal organizations called SAMHSA, that there's no one method for someone to recover. And that treatment should be offered to people based on their individual needs and also incorporate their co-occurring health conditions, whether that be treating an infectious disease, treating their mental health concerns, and in addition should address non-medical drivers of health, otherwise known as, social drivers. Some people refer to them as social determinants of health. But for example, the housing, or perhaps, addressing criminal justice concerns, previous involvement in the child welfare system, food insecurity, employment, all of these things that's really when treatment works best as we look at the person as a whole. One thing that we like to keep in mind with the big picture is that stigma and discrimination is profound towards this population, those who become pregnant and are parenting. And what it does is it limits access to care in a number of ways. And we have seen worsening health outcomes for this entire population, not just for the parent, but also for the infants who are affected. And we do have all of these points acknowledged by the government and have had special funding earmarked for for this population, and is there for this special population. Next slide. So this is a topic that, some of you may be familiar with and some of you may be new. And I certainly was new to this topic back about 6 years ago when I was an addiction medicine fellow who was just interested in providing care, mostly medications for opioid use disorder or other use disorders for pregnant people. I had no idea what this law was called Capta Cura. So we're going to go over just a few key terms. The slides are a little bit wordy, but you'll all get a copy of them and can have them as a reference tool. So in 1974, passed the Child Abuse Prevention and Treatment Act, and it provided federal funding to support prevention, assessment, investigation, prosecution, and treatment activities related to child abuse and neglect. It's undergone a number of amendments and modifications. We'll show a timeline on the next slide. Most relevant to our talk today is the amendment adopted in 2016 by the Comprehensive Addiction and Recovery Act. So what this did was clarify the population that was required to receive a term called the Plan of Safe Care, which we'll go over in a minute. And it clarified this to remove the term illegal from the plan of safe care as to who is eligible or should receive this plan of care. So it said that born with and affected by substance use, withdrawal symptoms, or fetal alcohol spectrum disorder. And it also modified the plan of safe care to include the needs of the infant as well as the caregiver. So that could be the family caregiver, or the parent. And it also specified what data should be reported through NCANS, the National Child Abuse and Neglect Data System, and specified that there should be increased monitoring oversights for states to ensure that these plans of care are indeed implemented and that families have access to appropriate services. In terms of the actual nuts and bolts of these plans of safe care, this amendment did leave it up to states to define what model would work best for them. There were some requirements for reporting pertaining to, the CAPTA grant is what it's generally referred to. And now, in this age, they could be called plans of safe care or plan of care, but they're also often called family care plans or family recovery plans. So those are just some general definitions. Next slide. Just a quick timeline and just kind of a quick review. Next slide. So a little more as to what is, a plan of safe care? Like, is it a piece of paper? Like, what is it exactly? And like I said, they can be called family care plans or family recovery plans. But in a nutshell, they're a mandated component of federal law called CAPTA. They are designed, its intention is to promote the safety and well-being of infants and their families when the mother has prenatal substance use. They're intended to be family-centered and incorporate multidisciplinary care teams. So that would range from physicians and healthcare professionals, public health, social workers, peer recovery specialists, home visitors, and state agencies, not just limited to child welfare, but also including then hospital entities as well, to collaboratively develop, implement, and monitor these plans. And the goal is really to support the health and well-being of these individuals and family members that are affected by substance use during pregnancy. Next slide. So this is just reiterating a little bit of what I just said, but I do think it is important to just remind everyone that it did remove the term illegal, and it did have addition of the infant and the family caregiver. And there are just a number of data requirements. So tracking the number of infants that were identified as substance exposed, whether or not they received a plan of safe care or family care plan, what types of service referrals were included, and also, whether or not the infant infected caregiver actually followed through and received those services. This article is really fascinating. And I think that it just takes, sort of these plans to the next level as we think about them. Did we actually plan for the safer care, or did we just widen, the net of who is involved in the child welfare system? And it reviewed, this was back in 2019 of where we are in states adopting this. And at that time, very few states had actually, between 2016 and 2019 been able to move forward. But with the help of, National Child Welfare and Children and Family Futures and a few other places providing training and technical assistance, and with the great work of, many champions in different states, great progress has been made. And I think it's just a good way to look at, like, did we actually follow through? Was this just a way that we just gathered more data without, planning for following through with those referrals? Next slide. So the reason, we're here today is to talk a little bit about the intersection of federal law, really with like state law, and even sometimes like, what happens within an individual county, and sometimes even within, like an individual hospital policy. So all of these can be interrelated. For the purpose of this slide, I'm going to talk a little bit about, what does the law say and what does the state law say? I will reflect back that, like, as a physician, I never really thought that this would be something that I would become so interested in. But it directly affected how I took care of patients. And it became abundantly clear to me that I actually did need to understand what was taking place, not just with policies, but also with Illinois law, in order to better care for the families that I was seeing within my clinical practice. So there's been a number of places that have studied actually, like, comparing, state laws with regards to this particular population of people who are pregnant who have substance use disorder or substance misuse. And we still have some states where it is actually considered a criminal act where one could actually be incarcerated. That's rarely the case in Illinois, where that happens. And in general, I have not seen this happen, though we do actually have a fair number of people who are pregnant, who are incarcerated, whether it is in county jail or in the prison system. But typically the reason for their incarceration is due to another crime. And it could be nonviolent and it could be a violent crime. In some states, there is mandatory drug testing for pregnant people, like all pregnant people at the time of delivery. So that still exists, and it could be even at the county level that this is taking place. And so if the test is positive for a non-prescribed substance or, an illicit substance, this could lead to involvement of law enforcement and child welfare. And a thorough look at like each individual state statute is really important to understand that criminalization of substance use in pregnancy. In addition, next slide. We know that like in many states, having, a positive drug test for a non-prescribed substance, or even in some states, a prescribed substance can mean a report to child welfare. In some states, it's meant to be a de-identified report, but it could turn out to be a report. So it gets muddled a little bit. But Illinois, if there is a drug test ordered on a newborn and it happens to be positive, for example, for opioids that are non-prescribed or for cocaine, for example, that is a mandated hotline report with the indication for neglect, and that would be at that time of birth. So that's, kind of where we are right now, despite efforts to identify substance use in individuals as a medical condition. So this is just a summary of, kind of like 2020 to present in Illinois. I start with that time as this just kind of like when I got into this work and started joining in on like taking a look at what's going on. So at that point in time, no plans of safe care model in our state. As I mentioned, that positive newborn toxicology is a mandated report. There had been a number of attempts to previously address this sort of like within the system, and maybe even some laws introduced that hadn't been passed. There certainly had been some attempts to sort of expand, who the definitions of neglect and abuse too, also weren't successful. And then just reviewing the CAPTA grant reports, certainly we're not fulfilling, the intent in terms of like, there's a lot of information on these families, like proceeded with, like these kids were adopted, very similar to safety plans. There wasn't much information on family-centered plans. And certainly there was no differentiation between notifications and reports. Simultaneously, colleagues were reporting that as well as, frontline state agency workers were just having challenges in providing services, engaging with individuals, retention in services, and really just like an over-reliance on drug testing while there was, high potency fentanyl, emerging, where most hospital drug tests obviously do not include fentanyl in their drug testing panel. And fentanyl stays in the system for a long period of time. So, follow-up tests, if they did include fentanyl, like in the outpatient setting, were often like very difficult to interpret those tests as to who was actively using versus was it, previous use, and how to interpret that. The other thing I'll mention is that there were really significant gaps in policies that, OB providers were really struggling with, which is like the classic, the open case. Someone's not parenting a toddler or maybe an older child, and they get pregnant again, and they're not using, or they're on substance use treatment now, and the clinicians were just saying, well, I didn't realize that they wouldn't be allowed to parent because that case has not been closed by the court system, and grappling with like how to ethically manage this patient, with when they would inform them of this possibility, et cetera, and just feeling like a lot of conflict with those situations, especially with very limited treatment availability, particularly during the COVID pandemic. And lastly, there's just really very limited knowledge amongst many people, including some non-child welfare agencies, about, what their parental requirements were for a plan of care, what their role would be, and certainly amongst, clinicians who are just like, I don't even know what you're talking about. So that's kind of, just the background here. Next slide. And then, of course, we've all are aware of, and if you aren't, that, maternal mortality rates were, all over the news as rising, in the United States, particularly after, COVID. That's when we got our data. And I just, messily highlighted here just to make a point that, like, these are, really concerning statistics for the state of Illinois, and they do match several other states with, substance use disorder is the leading cause of these pregnancy-related deaths, and they are considered preventable. And just showing that, like, we had a lot of public messaging about addressing this, and talking about it, trying to reduce stigma, but not a similar match in changing, some statutes and policies. So again, clinicians were reporting, well, what do we do with this patient who's really afraid to come in because of X, Y, and Z reasons? Or, well, what am I supposed to do? Have them, do the eat, sleep, console, but then take the baby away when we know the baby's not going to be able to go home with them? That seems really just a very challenging situation. So all of these things. Next slide. So I want to just talk a little bit about, where, several of us were at with, like, looking at, was it worth it to try to dip into this area, and, really like what would be sort of the best strategy and key issues. So the first really was, family separation. And I think that this is an important issue for everyone to really look at, because there was also data coming out about, separating the mom from the baby, even around the time of birth, is actually just associated with some negative outcomes for both mom and the infant, in terms of like increase of neonatal withdrawal symptoms, possibly, some emotional consequences for the infant or their development long term, and definitely at risk for moms to not retain in treatment, and increase their risk of overdose and death because they feel such a loss. And just, observation, it's a very unnatural thing to do, to separate at that time after you deliver a child, to separate a mom and her infant. It's very unnatural, and it feels it's very difficult as a medical provider to be involved in that process. And, as an intern, I was involved with that process when I cared for people in the criminal justice system in Montana. And it's a really difficult and uncomfortable feeling that you never can shed, to be honest with you. You can never shed it as a provider, participating in that. And, hearing back from children, as like, where's my mom? Or, I never got to be with my mom. It's all very challenging. And certainly there are the other sides of those cases of like, I never felt safe at home because my parents were using. It's really important to hear those perspectives too. The drug testing issue is very highly researched right now, but I will say that there is sort of an over-reliance, and even National Child Welfare has put out a number of messages of that, drug test is not an indication of parenting, and looking at the entire situation is super important, but yet that's in state statutes. Stigma is another reason to change policy and strategy. The fear of like systems when they are really supposed to help, with welfare of the family and the children, and mostly just seeing how people avoid prenatal care and substance use treatment. Some cloudy policies on open cases, as I mentioned, not being able to get answers from different people, caseworkers, the court system, where are we going with all of this? That is also a reason to change policy and have some clearer communication. And then, of course, having a public health focus with maternal mortality, what can we do system-wise to, make healthcare systems a bit more friendly and transparent, so that we can reduce those pregnancy-associated deaths that are related to substance use disorder and drug overdose. And then lastly, just, providing, accurate information, education on, what are the actual mandates surrounding federal law as it intersects with state law, so that states appropriately use the CAPTA funds as they were designed to. Next slide. So I just underlined some key ways to work with state agencies and other partners. So collaboration is a key recommendation. Education, so be well versed in best practices, the state statutes, child welfare manuals. I'm going to have to read them closely. It's difficult and challenging when you don't work in the field. Speak with and include people with lived experiences. That's extremely important. Many resources exist, free training and technical assistance. So go and get it. Take the time to do it as much as you can. There's so many modules, webinars, trainings, written resources, and continue to be an advocate for your service provider, for your clients, patients, community. Next slide. So that's kind of what we were doing. We did a lot of research. We rose awareness with some key medical societies, including the American Medical Association. There were several listening sessions that were held by different organizations, including the White House at the time, to really hear from patients and families and clinicians about this issue. Connecting with community-based organizations that have been involved in this work for some time. ICOI, which is Illinois Collaboration on Youth, the Movement for Family Power, ACEN Justice, Bronx Defenders in New York, and reading their reports carefully. And then just beginning on identifying, where are there points for collaboration between, state agencies, hospitals, perinatal quality collaboratives, and just raising the awareness that, DCFS or child welfare can't handle everything, and that's not their job. And just again, where are the points for collaboration here? Because everyone wants to help, and that's the sense that we got, is everybody wants to help, but maybe can't pull together all the time, or maybe everyone doesn't know what they're doing because it's behind sort of some closed doors. So that was a lot of this early work between 2020 and 2022. Next slide. So, I get asked this a lot, like why did you go through this legislative process? And I think the answer was that we had to, right? It wasn't to draw attention to any one agency or anything, but we actually, in order to make meaningful change, had to remove some statute in order to do so, in order to allow, really for this work to be done. And that would include like the state agencies. So there were some old punitive measures in place that actually needed to be removed. And that was like removed, modified, whatever you have. And that was actually really the starting point. And it also helped raise a tremendous amount of awareness across the state. There was some frustration that this had been encouraged for quite some time and no movement had been made. And again, simultaneously, the rising rates of maternal mortality, seeing family separation at high rates, which, a lot of that also falls on court systems and all of those things. And what families were reporting that it felt unfair, especially for individuals who didn't have legal resources. And then simultaneously, clinicians are asked to, expand their treatment and expand things like the Eat, Sleep, Console model, keeping moms and babies together in hospitals, but not really feeling like they could best support them through, sort of that advocacy process if child welfare is involved, getting them into like sort of intact programs, what are the exclusions, all of those things. So that's really like the best I can answer why legislation. And we'll go over a little bit of what that looked like. Next slide. So I want to give Dr. Amaya a fair amount of time, but I'm just going to quickly go over, how we did this. And I think just identifying bill sponsors, House and Senate, who are invested in maternal health. And I think that is really important, the maternal health piece, also like spanning the health of children. I think people can be pretty well educated on addiction, and should, be familiar with state agencies, and most policymakers are. Most importantly, I think they should be willing to collect co-sponsors and, talk up their bill in, either the House or the Senate, rather than relying on, lobbyists to do so. Of course, their role is important too, but they've also got to be invested in this bill. And then we chose a coalition or approach for writing the legislation. And these people need to be committed to actually making it a priority, have the lobbyists, and then also identifying people who can provide testimony during the legislative sessions. Next slide. So this is just a list, and I'm not going to go through all of these people, but, sort of the natural partners really are, people who are in the addiction field or the birthing field, like, harm reduction, doulas, et cetera. But I want to take a minute and then we'll kind of transition into Dr. Ramaya, but like, strategic partnerships are really key for this kind of work. So we worked with the Office of the Cook County Public Guardian, which brought a different perspective. They provide, attorneys for children, the guardian ad litem process, and they also work with states' attorneys. And they were really instrumental in helping write legislation that just makes sense, understanding what's feasible and not feasible, and writing and rewriting legislative text. It's an incredible relationship on this bill, and I strongly recommend looking at organizations or agencies that firmly represent children. So AAP, the Child Abuse Pediatrician Professional Society or group, practicing physicians like Dr. Ramaya's group that she'll speak about in a moment. That's extremely important. And I can't say enough about how that piece can help move a bill like this forward. Next slide. This is again just preaching the same thing. It's like we need to be partners, right? So it doesn't work without this, and have some patience for the process. Next slide. So it's a long process, like it could take 1 to 2 years, maybe longer. The bill that you get is like never the bill you will start with. In addition, don't hold your hope on like we're going to eliminate drug testing altogether. Like if you have that as your goal, it just may never happen. So try not to anchor to one particular piece is my recommendation. And that's what we all agreed as a group to not do. For this population, incremental change is better than no change because this population needs change as soon as possible. So that's what I really liked and learned about working on this bill, and it can apply to a lot of different situations. Next slide. We chose a task force approach to help, support the state agencies in a plan of family care plan model. And a task force is helpful because they have timelines, they have tasks, they have a wide variety of individuals appointed with different expertise, including lived experience. And its goal is really to collaborate, not to have, tons of infighting or anything like that. We've only had a couple of meetings so far, but I feel like it's going really well. And the chairs are actually policymakers. So that is also like a really great thing to really include them very deeply on this process. Next slide. So in summary, some of these lessons learned is patience. Like I can't tell you how patient that we've all had to be. Um, Work with organizations that have lobbyists and who are dedicated, like actually identify this, like this is the one bill, or these are the three bills, one of the three bills we want to pass this session. Use data and stories. So data is great. We'll try to put a face to the name or a couple of stories into promoting this bill. Be respectful, but call out stigma when you see it and hear it. Because if you don't, it just, people will that with lived experience and just clinicians or whomever, they will feel like no one's standing up for them. And I think that's something I just can't say enough is that there can be some very harsh opposition. It's very stigmatizing when it comes to bills like this. Implementation can take a long time, but holding people accountable, following up by email, phone call, etc., is really important. And lastly, we hear a lot that child welfare is everybody, child safety is everyone's responsibility. So is, the health and welfare of families and the life of the mother. I mean, they have the baby, but all during that time, there is a developing infant. So it's in all of our best interests to support the health and well-being of parents who might have substance use disorder. So reframing it, remembering that we all have common goals and shared values is something that I think was a great lesson and something I would suggest. Next slide. So I am just, I put this slide up as a transition slide to Dr. Ramaya so she can share some of her incredible expertise. And we'll just kind of go from there. But this is just showing that the AAP does support plans of safe care work and had this great policy and also put out some information for pediatricians at the same time. So, yeah. Okay, thank you.
Hi, everyone. Thank you so much for the segue, Dr. Fitzgerald. I do have to say, I was pulled into this because it came up and I'm the co-chair of COCAN. And it has been a pleasure working with Dr. Fitzgerald and learning about this area that we think about, but think about a little bit more in the abstract when we're taking care of children. And it's been an incredible learning experience. Um, I think, Maura, when I say click, I have like a little bit of animation. Yeah. So what is a CAP? In case anyone doesn't know, CAP stands for Child Abuse Pediatrician. We are a pediatric subspecialty. We are board certified by the ABP, the American Board of Pediatrics. We have been an official subspecialty. We became one in 2006, and the first board exam was in 2009. But if you look at the history, child maltreatment's been here in existence as long as children have been in existence, right? Historically, children were considered property, and it wasn't until the late 1800s, early 1900s, where it started to be viewed as, well, no, children aren't property. You can't kill your child, you can't neglect your child. And it started off as a social movement, and then it escalated into entering the legislation. So if you click, there's a picture of Mary Ellen Wilson. She is known as one of the first high-profile cases of child abuse, where she was removed from her parents' care and placed in, they don't call it the foster care system at that time, but placed with someone else. And the advocacy for her protection is actually what spawned the development of the institution of the New York Society for Prevention of Cruelty to Children. And medically, by 1962, C. Henry Kemp published one of the landmark papers called The Battered Child Syndrome. If you can click, there's a picture here of the original paper. And then since then, in the medical field, and especially in the field of pediatrics, there began an evolution of focus on paying attention to this as not just a criminal entity, but a medical entity, that the injuries and neglect of children is actually harmful to them. In the 1960s, states began passing mandatory reporting laws and establishing legal interventions. And then if you click again, in 1974, like Dr. Fitzgerald mentioned, CAPTA was enacted. That's actually a picture of the congressional hearings. If you recognize the gentleman in the middle, it was Senator Mondale at the time. Next slide. Just to walk down his memory lane, not my memory, history. So who are we? So the Illinois chapter of the American Academy of Pediatrics has several committees. I am the co-chair of the Committee on Child Abuse and Neglect. My co-chair is Dr. Kathy Swafford. She's a CAP in Southern Illinois, so they always want someone from different parts of the state. Our group is comprised of all the Illinois child abuse pediatricians, of which there are only 14 of us, and other Illinois child maltreatment experts. So our group is about 20 people. Our primary goals, in a nutshell, I was trying to make this as concise as possible, are advocacy and education. So advocating for children, advocating about legislation, providing education, mainly to pediatricians and medical providers around the state of Illinois. But that could also extend to families. And the way I got brought into this is that part of my role is to review legislation that's pertaining to child maltreatment. And the executive director, Jenny Pinkwater, and our lobbyist, Sean, will bring legislation to our attention that has to do with child maltreatment. Next slide. So just briefly, the landscape of child maltreatment, NCANS, Dr. Fitzgerald had mentioned, is part of a requirement of CAPTA to collect this data and put it into a report. The most recent report published in January was for 2023, and that year about 3.1 million children were subjects of a child maltreatment investigation. Out of that, about 590,000 were victims of child abuse and neglect. And in this report, they list the two highest caregiver risk factors for victims of all ages as domestic violence in 25.1%, and what they refer to as drug abuse, we call substance use disorder, in 24.9%. Now, just a reminder, this is not saying these cause that. It is a risk factor, and so there is some kind of relationship. That year, about 2,000 children died from child abuse and neglect. And out of that, you can see the numbers here of caregivers that had drug abuse as a risk factor or had alcohol abuse as a risk factor. And again, just to clarify, I use the language they use in NCANS just to be accurate, but we don't refer to it as drug abuse. Even in the pediatric world, right, we call it substance use disorder. To click real quick, a fun fact, just to reassure everyone, I know 3 million children is a lot of kids. It is a lot of kids. But just to reassure everyone, there are about 73 million children in the US. So I like to remind pediatricians that most of the children we take care of are not going to be abused or neglected. But that being said, we do not want 590,000 victims of maltreatment. We want it someday to be zero, but that is always the hope. Next slide. So just bringing it back to our talk of infants with prenatal substance exposure, in the US, if you can click, from NCANS, here's the data from NCANS. Now keep in mind the 44,453 children referred to CPS or Child Protective Services agencies, that's from states that report this. So this may be an underestimation because there are some states that don't report it. They have already created alternative pathways where these children or families are not being investigated. But these are the numbers we have. That's what we have to go off of. Out of those, about 73% are screened in for investigation or alternative response. And then you can see the numbers listed below of what percentage or what number or amount have a plan of safe care, and then a little bit smaller number of who was referred for services. And we always need data We should scrutinize how accurate it is, but we need data as a starting point to show the scope of the problem and identify the importance of making these changes. Another click. And then just to bring it home to Illinois, click again. You can get this information off the DCFS website. In fiscal year 2024, which I know was after the national data, there were 781 infants reported for what they call IPSE, infants with prenatal substance exposure, and 81% of those are indicated. And then click again. And that is out of about 125,000 live births in Illinois that year. Next slide. So our journey, oh, the confetti's going. As she mentioned, early 2023, ICAP COCAN was contacted for input. The pros of us being involved is we have to. We don't have a choice, right? CAPTA has been amended. We have to pay attention to this. We could sit back and say, oh, we just want to protect children. We don't want to take away the protections. But we have to have a consensus that the response for substance exposed infants must be improved. And we all know that. We already know that. We ourselves get frustrated when we see there aren't enough treatment programs, that kids may be being removed or kids may be being left in place too long who are not being monitored well. So those are the cons, is removing protections too rapidly without adequate protection system in place. And that was why we were very much on board with advocating for a task force. And then there is the other con that we hear of criticizing child welfare and pediatric providers for our efforts to protect children, which can be interpreted as punitive to the parent. I think I do admit we do get very wrapped up in preventing. We want to prevent the harm. We want to make sure it doesn't happen, but we also have to pay attention to making sure we're not preventing parenting from being able to occur and improvements in parenting. So what are the gaps that we've seen in Illinois are insufficient treatment systems for that parent-baby dyad, insufficient treatment systems for substance use disorder in general, and a lack of a monitoring entity. So again, the reason we wanted to push for a task force is historically DCFS has been the monitoring entity. But if they do not have the ability to handle it, or if they're still working on their systems to handle it, if we just pull away the reporting and we just pull away the investigation piece, pediatricians can't just fulfill the role of monitoring. So the great news, which is where the confetti was supposed to come down, was that that bill was passed in 2024, and that's the solution, is this task force provides a thoughtful and measured approach. And CAPS want to be part of that. Pediatricians want to be part of that. We strongly believe that there needs to be a different view of substance use disorder in order to be able to support and promote and facilitate and help babies stay with their families. Because nobody, in spite of the way it's portrayed in the media, in spite of what people may think, nobody wants to remove children. The system doesn't want to take more kids into foster care. And we do know from evidence-based medicine that substance use disorder is associated with maltreatment, more so neglect than abuse. But it is also associated, when you don't have plans of safe care and you don't have more good support systems and you don't have an adequate process, it is associated with more kids going into foster care. And none of us want that. And so that's why we are all in on this, and we were happy to provide our input. And I was able to go and testify and learn from this process. And we hope that this has been helpful to you to hear. And next slide. I think that was it of mine. Oh, and we're done with time to spare.
Yeah, that was great. And I'm just so grateful for the perspective you bring. And we learned so much from the role so that you played, and your testimony was truly outstanding and instrumental in passing the bill. I mean, I really just am incredibly grateful that we could have that partnership, and it's not one that we see enough in this space. I would really call attention to the fact that pediatricians struggle so much with how to support families. Now, I'm a family physician, so it's often a little bit different for us, but those who predominantly care for children and infants feel the same way. So with that, we'd love to open it up for questions, comments Can't promise we can answer everything, but yeah.
Thank you. Thank you for the compliment about the testimony. I do want to say one thing before we go on to questions is that really surprised me. And I think the audience should know that, like, when I went to testify, I had a bit of a maybe unrealistic view of, oh, well, I'm a child abuse pediatrician. If I go in front of this committee hearing and just say that I agree with this, that legislators are just going to agree with me. And as you, I don't know if you recall, there was a lot of pushback. I was surprised at how much pushback we got when we had a GAL sitting there, a guardian ad litem, and a child abuse pediatrician who I think sometimes people think might naturally be the groups that wouldn't agree with this, which is not true. It's just we want to figure out a good way that we protect the baby at the same time, right? We don't lose sight of the harms to the child. But I do want to comment that you may come across if you're trying to implement this or pattern this or do this, that I was surprised at how much pushback we got from legislators. And the hard part is it goes back to the stories. The different counties have the one kid, right, who died, who that was related to. And what I was trying to bring back, or everybody, all of us were trying to refocus is, yes, there are anecdotes, but there's anecdotes on both sides. There is the one case on both sides, but we can't lose sight of the cases we don't talk about, which are the success stories, right? The success stories where children are supported and families are supported, sorry, and children are kept in the home because they don't have as much of the shock value. And so when you come across that opposition, you just have to, like Dr. Fitzgerald was saying, know your data, know your facts, make sure to harness the conversation around looking at the bigger picture. And I think that really helped a lot.
Wonderful. Thank you both so much. We've got a couple questions that have come in so far. If folks have other questions, please put them in the Q&A box, but I'll ask it of both of you and then you can decide if one or both would like to respond. Our first question is, in the infants with the prenatal substance exposure slide, does that entail people on medications to treat their substance use disorder? There appears to be conflation between a person with the disease of substance use disorder and cause of abuse or neglect.
All right.
Want to
Can you
start?
the first part? So this is for a patient who's prescribed medications, and if that is considered abuse or neglect. Sorry, it's sometimes helpful if I can see the
Yeah,
question.
I can put this in the chat for you
Yeah,
both.
throw it in the chat just so I can make sure I answer it.
Oh, if you click on the Q&A thing, yeah, so there is that idea that there is that conflation, there's that misunderstanding. And this is where good education comes into play, because if you read the DCFS manual, it specifically says in there under substance affected infants or substance exposed infants that the investigators are supposed to take into account when a patient is getting treatment for something, if someone got like narcotics during the delivery, if they are on substance use disorder treatment, that should be taken into account. And we hope that doesn't get lost in the shuffle, but I've heard stories, and Dr. Fitzgerald can tell you of instances where that did happen, where there were misconceptions about that.
So yeah, I think this is really like a two-part question. So the first part is like if you're prescribed, a medication to treat your substance use disorder, would that put you at risk for being, a hotline report? The answer is in Illinois, no, this should not happen. Does it happen? It occasionally does happen. And what would happen in those situations that we've seen is that, typically like a nurse, in a smaller hospital will do it as like an abundance of precaution. Like, oh, I did like they don't know much. And they're like, I think this is the right thing to do. I should just make this call. And, the hotline, whoever takes the report is just like, okay, well, I'm going to just do this and we'll send them. But a lot of times they don't take the report. We can't predict what happens. So we do always tell, like, for example, our patient population, if you are not delivering with us or at one of the hospitals that really knows this policy, like we can't control what happens, but here's like some tools you can use to advocate for yourself, or you can call us and we can try to help. But we have seen where these investigations, have maybe turned up some things from the past, and suddenly, they're not allowed to be with their baby for a period of time. Typically, things work out and it's resolved, but there is a period of family separation or some monitoring or what have you that was not anticipated. And that's actually really been well documented in other states. So like one example would be in Massachusetts. This just recently revamped their law. But what had happened is when they did implement, a plans of care model, suddenly all individuals who are on medications for opioid use disorder were under that net. And that's really referring back to that article. Are we widening the net for people who don't need to be in the system? And the reason for that is because when someone is prescribed a medication like methadone or buprenorphine, and that's the only medication they're getting, the infant could still have neonatal withdrawal symptoms. And we want to collect that information per this CAPTA law. We don't necessarily want to have that reported for like a neglect because we want people to be on medications, if that makes sense. So it's really like a very, it wasn't the intent, but that's what ended up happening. And then there's been a lot of talk. It was like, well, just because they're on medication doesn't mean we don't not want to know about this family. Maybe they do want some services. They typically do not want services through child welfare. Like they might want them through public health or community-based, but they don't want them through child welfare because they don't want that, sort of regulatory aspect. In terms of there appears to be a conflation between the person who has a disease and the cause of abuse and neglect. Yes, that does exist, and I will leave it at that. Is that what we're overall working on? There have been changes at different paces, but still, by statute, that is very much the case. So,
Thank you both. I think we might have time for one more question. How will the outcome of these changes be followed? This attendee would be interested to see if this encourages disclosure with care providers and how that could be tracked.
yeah, I have some information. I think that, I think first of all, like the task force has like a very specific role, is held accountable, has to produce a report within a year, et cetera, et cetera. At the same time, I can say in Illinois, there is, suggested pilot project for family care plans that's been very thoughtful, that has a number of data points, surveys, et cetera, for that. And I think there is, more of a spotlight to implement this. So I think just like, just because like this bill could mean nothing. Like it just could mean like, oh, we have this and no one could ever do anything with it. But there are still that same committed group of people who want to actually ensure that people do follow through and are held accountable in a number of ways. Like how many care plans do we make? How many people get a referral for whatever services they said they wanted? And how many actually get those referrals followed through. And, there's just like a number of things where we could track. And I think other states have done this, like New Mexico, for example, the state of Washington, Connecticut, Vermont. So there's other places that we can look to see, how we do this. And we work with also public health because they also have a reporting system called APORS and where you can look to not duplicate similar kind of work. So that's kind of my answer in a nutshell. Dr. Amaya, anything to add?
And to be clear, the purpose of the task force, right, is to implement a system that's safe for everybody, right? That, kids are still kept safe, even when you peel away the layer of investigation and child welfare. So that's one piece that had to be the compromise, is that we as, like groups, were not willing to just take away reporting without safety nets being in place. And so that's why this is a great stepwise approach is, yes, I'm more than happy to have reports to DCFS taken away and flipped into a notification system, but not just right away without any monitoring and safety to the child. And so that's what's actually happening here, is that this will be a good stepwise approach of implement a system of notification while you're doing the reporting, implement the systems, buff up or make more robust the systems or treatment options or the pathways to support the families and their babies. And then you take away the reporting to DCFS. And then hopefully that means that you remove some of that punitive nature. And so that's ultimately the goal and the mandate, right, of the task force is to create a system like that before we before we remove that safety net for children. And I think that's the safest way to do it, which is why there's so much buy-in. Which is why that collaboration and like you said, being patient and being willing to take a stepwise approach. So thank you everybody for having us.
Thank you all so very much. Thank you, Dr. Fitzgerald and Dr. Ramaya, for sharing your expertise and your wisdom with us. As everyone leaves the webinar, you should be directed to a quick evaluation. And I also wanted to share really briefly, we have a really great, as part of this project, a replication project opportunity for perinatal substance use disorder policies and practices. And the Illinois Family Plans Implementation Task Force Act is one of those. So if anyone is interested in learning more about this opportunity, it's an opportunity for 3 organizations to replicate perinatal substance use disorder policy or practice. Feel free to email me directly, and we just launched the opportunity yesterday, and I'm happy to share some more information with you all about that. So thank you all very much again. We'll follow up in the next couple weeks with slides, recording, and just a summary resource for you all to share. Thanks, everyone.